Hey folks, we're back to talk a little bit more about articulations, a little bit more today in regards to how particular joints move. In our last presentation, articulations one, we talked about the different types of joints. And our biggest concern at that point, or the biggest thing that we talked about, was about synovial joints, which are freely movable joints. However, not all joints are capable of moving in the same direction or have the same limit of motion from one joint to another, and that's what we want to discuss a little bit today, as well as talk a little bit about how the joints actually start to move and some of the names for particular motions that we'll see. So when we talk about different types of synovial joints, one joint that we have is called a planar joint, okay? And this is where we see between a lot of the smaller joints in the hands and the feet, the intercarpal joints, the intertarsal joints, the acromioclavicular joint. There's, again, between the clavicle and the acromion, there's a small joint inside there, but it's planar. By a planar, we mean that the joint is really flat. If we look up in here, you can see like there's two flat surfaces. And what happens is basically because I have one flat surface here and one flat surface here, they can only slide on each other back and forth or side to side. And it's called a planar joint. There'll be a little bit, if I look at between this plate and this plate right there, there'll be a little bit of a gap, which is that synovial joint. But the amount of motion, the degree of motion, is only side to side in different directions. It's flat. It's like sliding something like along the floor. Just basically, that's the type of motion that we get in what's called a planar type of a joint. Okay, it's non-axial because there's no real rotation around the axis. If I look up in here, this would be the axis right here, this thing right here. But what happens is, since it's not moving around there, it's only sliding, gliding along this a flat plane. It's called a planar joint. Okay, and again, it's where we don't need a whole lot of motion, such as again, the intercarpal joints, the intertarsal joints, things like that, sternoclavicular joint, acromioclavicular joint, where I don't need a whole lot of motion, very minimal motion. And it's basically a sliding along a flat plane. Second type of joint we have, which is a lot more common, is a hinge joint. Now, we talked a lot about the hinge joint in the elbow, right where the trochlear notch of the ulna fits over the trochlea. Here's a trochlear notch of the ulna right here, fits around this trochlea of the humerus, okay, and creates a hinge. The thing about it is it's sort of like when we look at the diagram to the right over here, this diagram over here, what we actually see is there's sort of like it allows like a hinge on a door. It rotates just in one direction. It's an opening and closing motion that we see. So when we flex and extend our elbow, that's basically around this ulnar humeral joint. That's basically where the trochlear notch fits around the trochlea. Okay, it's monoaxial. Monoaxial only works in one direction. That's flexion and extension that we'd see, so around a singular axis. And again, the typical examples of this are the knee, the elbow, the ankle, with the talus sitting inside that ankle mortise, like we talked about briefly in our last presentation, and the interphalangeal joints is very typical where we see these hinge joints. Again, it's only one direction of motion around that pivot, okay, and that's what we call a hinge joint. Another type of joints that we call a pivot joint, okay, and this is where we actually have a rotational motion. Now, this we'd actually see here. Here would be the ulna. This right here. Here's the radius right there. We talked a little bit in lab about how that head of the radius, that disc that we have up in this area, sits inside this ligament, which is called the annular ligament, which goes all the way around the head of the radius, and that allows the radius to rotate. Okay, so we see it in this diagram here. This would be the area, this would be the annular ligament that would be in here. Here would be the radius, that would be the head of the radius sitting right here, and how it's able to rotate in a circle around this area, and that's called a pivot joint. It's monoaxial because it's only working in one direction. It only is that rotation around that long axis. Here's the long axis becoming this way. It's only the rotation around that. We see this also at the atlantoaxial joint. We talked about how the dens fit inside that little notch on the back of the axis. And fitting in that little notch on the side of the atlas, and as a result, that's what we see. So the radioulnar joint, the atlantoaxial joint, is a typical example of what we call a pivot joint. Okay, that should be pretty self-explanatory. Third type of joint we have is called a condyloid joint, and a condyloid joint is not the typical round joint, but it's more oval shaped. It's ellipsoid, okay? So if we look at this, and what we see, the perfect example of this is here where the scaphoid or the carpal navicular meets the distal end of the radius, okay? And what happens is because it's wider in one direction and longer in the other direction, what happens is there's a little bit of an unequal motion from side to side and forward to back. It's actually biaxial because now it can work in multiple axes, because now you have a sliding along this whole surface right here in this direction or in this direction, and again, depending upon the length of the joint will determine how much degree of motion that we'll actually have in there. So it's an oval convex type of a joint, where one bone, such as we see right here in the navicular, sits in a concavity in the area of the radius, which is allowing it to move in that direction. Typical example again is the wrist joint, and also the metacarpal phalangeal joints, second through the fifth will be more condyloid type joints because they're sort of more ellipsoid or oval shaped as compared to being round. Okay, and that's called a condyloid joint. Another type of joint we have is called a saddle joint. Now these are pretty complex, okay? And this is not really a great indication. This diagram here is not really great to show, but think about riding a saddle. A saddle has different curves in different directions. You know, there's a front to back curve, there's a side to side curve, which allows, because these curves are in different directions, allows multiple more than one axis of motion. So the articular surface of one bone, which is sort of saddle shaped, will meet with the opposite bone, which is also saddle shaped in the opposite direction. So it's basically sort of a modified condyloid joint, but it has a little bit freer motion. It could move in multiple different directions. It could rotate, it could move up and down, simply because instead of being perfectly round like we found in a condylar joint, it is more contoured. So like this area right here, it would be contoured more like this, or more concave, where now it's convex here, and as a result it creates a sort of an unusual motion, more biaxial, multiple axis, side to side and up and down movements. Typical example, the carpal metacarpal joints between the trapezium and the metacarpal of the thumb, the calcaneocuboid joint, which we saw in the foot, with the calcaneus being the heel bone and the cuboid being that bone that's just immediately distal to the calcaneus, as we saw in the lab. And that's called a saddle joint. Okay, it's not one of the more common joints in the body, but it does allow multiple degrees of motion. Okay, and that's called a saddle joint. Now, this is the one everybody likes to talk about, the typical ball and socket. And the prototype of this is basically the hip. If we look at that hip, remember we had the femoral head. Here's our femoral head sitting right here, and fits in that large, deep socket. Whoops, again, my cursor's not doing what it's supposed to do. Fits this large, deep socket in here in the area of the pelvis. Get rid of these so you actually see a little bit better. Sits in that deep socket that we see in the pelvis, okay? And that's so it's basically a ball, which is the head of the femur, inside a socket, which is we see in the area of the pelvis, okay? Now the good thing about this is it's multi-axial. It's sort of like it can rotate in all kinds of different directions. So therefore, in joints where I need a lot of motion, such as in the hip as well as in the shoulder, these are very advantageous. You just have that ball that fits inside the socket and results in motion that occurs in multiple planes, which is actually great. The great thing about this ball and socket joint, which is very nice. Okay, it's multi-axial, and that's what's important to remember about this. It's a typical prototype of what we think of joints, but even though it's not the most common, but what happened, or not, I can't say not the most common, but it's not all joints, but it is the joints where we do need a lot of motion to occur because it is multi-axial. It occurs in multiple different directions. Now, we also talk about different types of, synovial joint category motions, and angular. We talked about different types of motions that are produced because of the shapes of these bones. Okay, when you look at a joint, the shape of the joint will dictate how that joint is going to move, whether it's round, ball and socket, whether it's a saddle, multi-axial, or biaxial, whether it's a planar, uniaxial, only in one direction, flat plane. And so basically it results in a number of different types of motions. And I just want to describe some of those motions because these might be important if you're asked to take an x-ray where the person is with a joint in a particular motion, or what they might want to see. They might say, I want a supinated view, I want a pronated view, and we're going to talk about what these motions, or these words for these particular motions, really mean. Gliding motion. A gliding motion is not, don't look at these arrows down in here. Don't look at this, that's an X, right? Don't look at this, don't look at this right here. But a gliding motion is basically where we have flat bone surfaces moving back and forth on each other, and that's what we're seeing up in here. This is a gliding motion. Again, this is what we see in those planar joints that we talked about earlier. There's really no angular change. It's just a slide. There's no change in the angle of the hand to the forearm. So forget this stuff over here. Forget this stuff over here. Just look at this right here. This is what we want to look at. A little smiley face in here. Okay. This is what we want to look at. And if I look at the hand moving just side to side in this direction, going back and forth, that's what we call gliding. So there's no angle change. This would be an angular change over here. This is an angular change, and that's a little bit different. Okay. So basically, these are at planar joints like we talked about before, and this is called gliding. Okay. That's that. The name for this type of motion is called gliding. Okay. Talk about some other things. Flexion extension. Now flexion extension, flexion is just a word that means if I have two bones, that the angle between those two bones decreases. Okay, so if I flex my elbow, what happens, I'm bringing my hand up towards my shoulder. The angle between the forearm, which is basically the radius and the ulna, and the upper arm or the humerus decreases, and that's called flexion. Okay, extension is now an increase of those angles. So now I have to take my hand, which is up on my shoulder, and extend my arm and put my arm straight. That angle between the forearm and the upper arm is increased, and that's called extension. This is usually sagittal plane motion, and we know what sagittal plane would be. It can occur in hinge joints, pivot joints, condyloid joints, saddle joints, and ball and socket joints all will have the possibility of having flexion extension showing that. Okay, lateral flexion is what we see in the frontal plane of the trunk, and I'll show that in just a second. And hyperextension is actually going beyond the anatomical position. You know, sometimes you'll see somebody and they'll extend their elbow and it looks like their forearm is now angled backwards. Okay, and that would be called hyperextension of the elbow. So you will see that sometimes in the fingers and stuff like that. So let's look at what we're talking about with some diagrams. Now this is flexion extension of the head and the neck. If I take my head and move it forward, okay, in this direction, that's neck flexion. So the neck is now flexing. The angle between the head and the torso is becoming decreased, and as a result, that would be called flexion. When it goes back to this point up in here, that's called extension. And then finally, if I go beyond that, back in here, that's called hyperextension. Hyper means excessive. Okay. Let me get rid of those lines there. If I'm looking at the shoulder, if I'm taking the arm here at the side and moving it this way, the angle between the upper arm, or the upper body, and the arm is getting shorter, so that's a flexion. When I bring the arm back this way, that's called extension. And if I go beyond this neutral position of extension, I go back this way, and that's called hyperextension. So that's flexion, extension, hyperextension of the shoulder. If I look in here, this is that elbow like we were talking about. As I bring that arm up this way, it's flexing. If I'm going the arm this way, it's called extension. That's what we mentioned before about the shoulder, arm coming up the shoulder. Then the hand. If I take my hand and move it this way, it's called flexion. Getting back to that neutral position is to extension, and going beyond that is called hyperextension. Sometimes they call this palmar flexion, and sometimes they call this dorsiflexion, or dorsiflexion, or dorsiflexion, because it's going dorsally. But basically the proper way to look at this would be flexion of the wrist, and this would be called extension of the wrist down to here, and hyperextension is going down towards the bottom, as the diagram will show. So that's a little bit about that. This is looking at the hip. Okay, if I take my hip and bend my hip this way, it's flexion. If I take my hip and come back to neutral, it's extension. And if I go back beyond that, that's called hyperextension. Okay, and this is my knee. Knee, if I bend my knee, bring it back, it's flexion. I come out to neutral, and that's called extension. So the angle here is getting greater, extension. The angle here is getting less, and that's called flexion. So that's flexion. extension that we see. Abduction and adduction. We talked a little about this before. Abduction is moving away from the midline. Okay, so if I look at the arm, if I'm taking my arm and moving it away from the midline, that's called abduction. If I'm taking my arm and moving towards the midline, that's called adduction. So that's abduction, adduction. So moving away from the midline, here's my midline of the body that would be here. Moving away would be called abduction, or sometimes you'll hear people say abduction, abduction. And if I'm moving it towards the body, that's called adduction, or sometimes people say adduction. Because if I say abduction, adduction, sometimes if I'm speaking fast, like I typically do normally, what happens is it might be difficult to discern whether I'm saying ab or ad. So a lot of people say abduction or adduction simply because it's easier to do that. Okay, so that's that of the shoulder. This would be looking at the leg. So basically, if I take the leg and move the leg out to the side, that's called abduction. If I bring the leg back in this way underneath the body, that's called adduction or adduction. Okay, abduction for adduction, and that's the same thing we had there. And with the hand, okay, if I'm taking the hand and moving it side to side, that's called abduction. When it comes back to the middle, it's called adduction. I haven't used that a whole lot as a common term, but that's something you should know. Okay, circumduction. Circumduction is basically a combination of a lot of motions where basically we take a joint and move it in a circular manner. The body part is moved in a circular or arc-like motion. Okay, this is a result of a combination of a lot of things. It's a combination of flexion, abduction, extension, adduction all together. So it's a combined type of a motion: flexion, abduction, extension, and adduction all together. And hip and shoulder are common examples of where we see circumduction. Okay, if I'm looking at the arm and if I rotate it around in a big circle around the body, that's called circumduction of the arm. Circumduction of the arm. And if I take the leg and rotate the leg around in big circles, that's called circumduction of the leg. Okay, and so circumduction is moving the extremity in a arc-like motion in a circle. Rotation. Rotation is revolving around the longitudinal axis of something, okay, where it's basically a pivot or ball and socket joint are the types of joints that will provide this type of rotational type motion. If it goes towards the midline, it's called internal or medial rotation, and if it goes away from the midline, it's called external or lateral rotation. Okay, and also we go back to what's called when I talk about the anterior surface. Now, what do I mean by anterior surface? Let's go back a month, 6 weeks, and talk about anatomical position. So if I look at somewhere in anatomical, that's why we stress the importance of understanding what anatomical position is. We know that anatomical position, everything is facing anteriorly, is what we see in that typical anatomical position, such as the palm, such as the front of the arms and stuff like that. And if that rotates inward, that's called internal or medial rotation. And if that anterior portion of the extremity rotates outward, that's called external or lateral rotation. So if we could do that with the head. And this is rotation of the head, side to side type of rotation. If I took the shoulder and I rotated the arm inwards, this is medial or internal rotation. If I go outwards, that's called lateral rotation. So if you take your arm, put it straight out, flex your elbow at 90 degrees. If I rotate that whole humerus inward, where now my arm is against my abdomen, that's called internal or medial rotation. If I now rotate it outwards, it's called lateral rotation. You're going to see you have a lot more medial rotation than you do have lateral rotation if you tried that. Same thing with the hip. Internal rotation, medial rotation, lateral rotation. If the femur rotates inwards, that's medial rotation or internal rotation. If the femur rotates outwards, that's called lateral rotation. Okay, there's some special movements I should just mention simply because these are sometimes tossed around, such as elevation or depression, protraction or retraction, inversion, eversion, dorsiflexion, plantarflexion, supination, pronation, and opposition. And these words are some words that you should probably know as well. If I look at elevation, depression, a lot of times in this situation we're talking about an upward elevation means an upward movement of a part, such as in shrugging the shoulders, which elevates the scapula. The scapula moves upwards to be able to shrug the shoulders. If I move the shoulders down or lower the shoulders or depress the shoulders, that's called depression. Okay, so if something's moving upwards, it's elevation. If it's moving downwards, it's called depression. Doesn't take a rocket scientist to figure that one out. So in other words, we can also look at the jaw. If the jaw goes up, it's elevation of the jaw. If the jaw goes down, it's depression. Going up, elevation. Going down, depressed. Piece of cake, easy. Guess what? That won't be on an exam. Protraction and retraction. A lot of times we look at this in regards to looking at the mandible. Okay. If I take my jaw and move, and so if you sit there while you're listening to this, you take your jaw and you move it forward, okay, and you stick your bottom teeth out in front of your upper teeth, that's called protraction. So the movement of the body part in an anterior direction. So my jaw, the mandible, is moving forward as compared to the rest of my skull, and that would be called protraction. Now if I take my jaw and pull it backwards, back towards my ears, which is hard to talk right now, but if I pull it backwards, what happens is now the lower teeth are behind or posterior to the upper teeth. That's called retraction. That's retraction of the mandible. Okay, and if I'm looking here at what we're talking about, protraction, the jaw is going outwards; retraction, the jaw is going backwards. Protraction and retraction. Okay. Inversion and eversion, and these are commonly used words, okay? And inversion, moving, is basically, a lot of times we're going to refer to this as in regards to the foot, okay? When the movement of the sole or the plantar surface of the foot goes medially, it's called inversion. So if you take your feet while you're sitting here listening to this, and you point the bottom of your feet together against each other, so the plantar surfaces of the left foot is facing the plantar surface of the right foot, okay? You move them both inwards, that's called inversion, okay? Eversion would be just the opposite, where I take the plantar surface of my feet and moving opposite. The soles, the plantar surface is facing outside. This is important because if you do this, okay, I just want you to try this. If you take one foot, I don't care, left or foot, whichever you like the most, okay? I don't care, left or foot, right foot. If you turn your foot in, it goes in a long distance. If you go out, it doesn't go out nearly as much, and that has to do with the fact that we talked about in lab how that fibula is longer than the tibia, extends a little bit more distally, and prevents some of that lateral motion. Well, what does that mean? Clinically, it means that what happens is when someone steps in a hole or turns their ankle inward, there's a lot more inward motion, which then stresses, as we talked about in Articulations 1, the ligaments on the lateral aspect of the ankle. They get stretched out and they may rupture. So a lot of times, about 90% of all the ankle sprains involve the lateral ankle ligaments. Why? Because there's a lot more inversion motion of the ankle than there is eversion motion. Okay, and that's just a little clinical application of what we see with inversion and eversion. So in other words, inversion, when the sole of the foot or the plantar aspect moves inwards, and it's called inversion. Outwards, eversion. Okay, that should be easy. Okay, dorsiflexion and plantarflexion, and this also relates to the foot. If you're now sitting there and you pull the top of your foot, the dorsum of your foot, upwards towards your knee, that's called dorsiflexion. And if you take and you put your foot and you point your toes downwards, that's called plantarflexion. Now, when we talked about inversion being greater than eversion, if I look at dorsiflexion versus plantarflexion, you see that you have less dorsiflexion and more plantarflexion. We talked a little bit about this in Articulations 1, where the back side, the posterior side of the talus, is narrower than the anterior side of the talus, which is wider. Okay, so as a result, when I dorsiflex the foot, that wider portion of the talus gets jammed between the tibia and the fibula. We talked about how that puts a little bit of stress on that syndesmosis, that connection of the ligament between the tibia and the fibula, and that sort of stresses out, and that's where we get our high ankle sprains. As well, if I put my foot downwards, okay, or plantar flex, what happens is now that narrower portion of the talus fits between the medial and lateral malleolus inside that ankle mortise, and there's a lot more play, there's a lot more motion, which also that plantar flexion is frequently associated or combined with inversion, which is a result why we have more inversion type sprains. Okay, so if I look here, foot going upwards, dorsiflexion, foot going downwards, that's called plantarflexion. Piece of cake, easy. Okay, supination and pronation. Now, supination and pronation. Supination is basically where the forearm or something that's anterior, okay, is turned. Is facing upwards. Okay, so the movement of if I take my forearm and I put my hands out with my palms facing upwards, my hand is supinated. The palm is facing upwards. In supination, something that's anterior of the body in anatomical position is facing upwards. Okay, pronation is just the opposite. Now if you take your hands and stick them out in front of you, okay, bend your elbows, stick your hands out in front of you, and you look at your palms are facing upwards. Your forearm is now supinated. Now if I take my hand and rotate it and turn and rotate it around so my palms are facing downwards, okay, and again those palms are normally anterior in anatomical position, so if my palms are facing downwards, that's called pronation. Okay, we could also have supination of the foot as well as pronation of the foot as well. In pronation of the foot, what happens is the medial aspect of the foot goes down and the foot turns out, and where it happens is in supination, the foot is more turned inwards. Okay, so this is going to be a pronation of the hand, looking at now the palmar surface would be facing downwards. This would be supination of the hand. Now the palmar surface is facing upwards. Okay. Opposition. This is what sort of makes us human, and one of the things in evolution we find that if we look at some of the lower primates, what happens is they don't have they start to develop what's called an opposable thumb, and opposition just means if I take that thumb, I'm able to pull that